The last speaker is Caroline Prince. She's a physiotherapist, sports physiotherapist from La Tour à Genève. And she treats mostly tendon and muscle injuries. And she just finished a PhD about hamstring muscle mechanical constraint during the sprint running acceleration. Welcome, Caroline.
Good morning, everyone. I'm really happy to be here in Lausanne. I believe this is not the last version of my talk I provided this morning, but that's all right. Let's go for it. So I'm really happy to be here, and I want to thank the organizing committee for allowing me to talk this morning on a very interesting topic such as structure and function, which I will address through the lens of muscle and specifically muscle rehabilitation. So this talk is going to be organized in 3 different parts. The first one being a reminder of how structure and function may interact at a muscle level. I just want to add right now that the function and the structure are going to be seen really as a biomechanical approach, so mainly as a force production capacity sort of function. The second part is going to be, I'll provide some evidence of how injury can alter the function and structure relationship. And on the third part, again, I will provide some evidence of how rehabilitation and training may restore this structure and function interaction. So let's start with the first part. It is well known now that the muscle size, the muscle fascicle size and its arrangement inside of the muscle are the primary determinant of muscle function, being muscle force generating capacity. And we have evidences now of strong correlation between the muscle size, so being either the muscle volume, the cross-sectional area, whether it is physiological or anatomical, and muscle thickness. So we have a strong correlation to maximum voluntary torque. And if we push this relationship a bit more onto the field, we have evidences of relationship between muscle size and, for example, in this case, sprint performance. And we know that athletes with the biggest hamstring muscle are also the one with the best sprint mechanical properties and also best sprint performances. So the bigger the hamstring, the faster the sprint. And we've also seen yesterday some other data about calf volume and sprint property. But of course, muscle size is not the whole story. And when we think about force production, we also have to think about force transmission. And by this, I'm thinking about all the passive structure that comprises the muscle tendon units. So, for example, the free tendon or the aponeurosis. So if we look at these structure and how they interact with function, we can see that same as contractile elements, the free tendon size tends to be correlated to muscle function as isometric strength. However, the aponeurosis size tends not to be so related to isometric or dynamic strength. And this might come from the fact that, contrary to the tendon, the aponeurosis receives tension on the longitudinal axis, but also on different axes due to the attachment of some muscle fascicles. And also, I think from listening yesterday to different talks, I think it might come as well from the fact that there is so many variations in aponeurosis types, shapes, that it might infer with this relationship. So now that we've some sort of reminded the structure and function interaction, let's see how injury can impact this. Well, in terms of structure, we know that there might be some CSA deficits, so some atrophy of muscles up to 6 months after a muscle injury. It tends to be normalized after a year or a bit before, but it can last for over a year. And interestingly, one study reported that up to 85% football players go back to training, go to sport, with a residual atrophy in their biceps femoris long head which I think is quite a lot. But in the meantime, if we look at function assessments, we can see that strength deficits tend to be normalized at return to sport, which looks, I think, what seems to be logical considering the fact that we use strength as a criteria to validate return to sport. But how can we explain this apparent imbalance between structure and functional assessment? Well, there is this really nice study who explored the volume of biceps femoris long head after injury, and they reported an atrophy on those injured muscles, but they also reported an hypertrophy of the biceps femoris long head in red, short head, sorry, in red. So this might be a compensatory effect from one agonist muscle to try and compensate for the atrophy. Does this question our current return to play criteria? I don't think so. We still need to measure and assess strengths, but maybe it questions the way we do it, because obviously with the tools that we have in clinical practice, we cannot see strength deficits only on the biceps femoris long head. Or if you know how to do this, I'd be very happy to know. So let's see how structure and function interact, but this time a bit differently, and see how we can go from functional deficits that we observe in clinic and to hypotheses about structural alterations. So you may be really familiar with these isokinetic assessments, and what you probably use a lot is the maximum peak torque here. But what you might not be using too much is the actual angle at which this peak torque appears. And this metric is quite interesting when you refer to muscle injuries, because we've seen that on injured muscles, there is a tendency for this peak torque to shift towards shorter muscle lengths. So here, don't get confused, the knee joint is increasing, but because we're referring to hamstring work. So greater angle, but shorter muscle lengths. So based on this clinical evidence, what sort of hypothesis can we make about the structure? Well, it was hypothesized, and we don't have clear evidences of that, even though there tends to be some data. We still need some material about this. But it could be explained by a reduced number of in-series sarcomere, which leads to a reduced fiber length, and which reduces the optimum length for force production. And this sort of context has been sort of proven to be one risk factor for further muscle injuries. So let's get back to the aponeurosis and how injury can alter this. Well, this area is still sort of debated in the literature. We have not big consensus yet, but we tend to see that injury may reduce the aponeurosis size, whether it is the width or the area or the ratio between the aponeurosis area and the muscle area. But we've seen that, I reported previously that it's not related to muscle strength, so is it really important for us that this is impacted by injury? Well, we know from this really excellent study based on finite element simulation, we know that if you reduce the size of the aponeurosis, then you might increase the strain on the muscle fibers that are attached to this aponeurosis. So of course, this is not real data, this is modeling data, but I think it gives us some material to think about, because if you consider that strain is one key element in muscle injury, I think then the aponeurosis size really matters for us. So, we know that injury may impact the structure and function relationship, but how does this apply for us in our daily basis practice? And before I get further, I just want to ask you one question to all the clinicians, the trainers here. So to which extent do you think that you can interfere with muscle structure? So on your daily basis practice, to which extent and which element do you think that you can actually improve? To illustrate my answer, I'm going to present you this really nice study. In this study, they explored the impact of training on muscle size, and they used two different exercises, hamstring strengthening exercises, the Nordic one and the hip extension one. And what they found is that after 10 weeks of intensive training, while muscle CSA is not improving a lot. Actually, if you look on the left graph, you have the biceps femoris long head. So just imagine that is the proximal part and that's the distal part. And each level is a percentage change of CSA from the beginning of the training to the end of the training. And what we can see is that the Nordic hamstring does not really have an effect on CSA improvements. But we have different insights when it comes to semitendinosis. So what do we need? What do we need to remember in our clinical practice? Well, that of course rehab may impact muscle structure. However, increasing the muscle CSA is not that easy. It's not that straightforward. It's muscle region dependent and it's exercise dependent. And I think having this in mind helps us increase maybe the rehab framework that we can do. If we keep on pushing on this muscle structure impacts with the training and rehab, and then we go a bit deeper onto the microstructure, and then we think about fascicle lengths, we found that this study reported that, okay, after 3 weeks of training of Nordic hamstring exercise, you can increase hamstring strength, which is a good news. But if we look at the adaptation in terms of microstructure, then the changes are not really uniform. You can create some fascicle lengthening, but mostly on the distal part of the biceps femoris long head, and not so much onto the central part. And in this study, the proximal part was not studied. But just for maybe you know that already, but most of the biceps femoris long head injury appears at the proximal part. So how could we explain such non-uniform adaptations? Well, we can have a look at how those exercises work in terms of functional demand in the hamstring. And if we look here, you have two charts about the electromyographic activity. So that's the electric signal on the surface of the muscle from the biceps femoris, from the semitendinosis, and it's pretty much similar to what we have before. You have the proximal part, the distal part, and then this is all along the exercise. The more yellow, the higher the activity. And what we can see here is that it's almost white on the semitendinosis, so it's clearly the electrical activity is clearly higher on the semitendinosis, so which might explain why we have differences between semitendinosis and biceps femoris. If we look at the biceps femoris, the electrical activity seems to be higher, but on the distal part, which clearly makes an echo to the structural differences that we had previously. And one other thing, if I can start again, yeah. You cannot really have high activation on your hamstring muscles if you cannot go towards the end of the exercise. So you really need to be able to maintain the tension on the hamstring to be able to sort of highly activated your hamstring. So I think this is one of the reasons that we have such differences in the results that we found in the literature, is that I'm not sure that everyone is able to maintain such tension in the hamstring when doing this sort of exercise, but it's necessary to create some muscle adaptations. So we've been talking again about the non-contractile elements, and let's see how rehab can interact with aponeurosis hypertrophy. Well, there is still some debate again from this point of view, but looking at this study, they explored the effect of eccentric exercise, but with one component being the lengthening state of the muscle. And what they found is that by increasing the length of the muscle, you can increase both muscle hypertrophy, but you can also target the biceps femoris aponeurosis, which was a bit different from other study, looking only at normal length, average length muscle. So this might be one key element if we want to increase aponeurosis size, is maybe to consider lengthening state of muscle. And also, I would like to show you the 12-week training, which is, I think, one of the biggest training study that I've seen so far. And this key element might be one of the key components to target non-contractile elements, to increase the training. So to wrap up this presentation, yes, we have lots of interaction between structure and function at a muscle level, and injury can impact this relationship in a short-term and in a long-term perspective. And hopefully rehabilitation can promote healing of that structure and function relationship, but maybe we need to stay a bit humble about what we can or cannot do. And yeah, I think we still have a lot to understand, but I think having this sort of information, biomechanical, physiological, and all that type of information helps us drives better rehabilitation and helps us recreate the function and structure relationship. Thank you very much for your attention. And is there any questions?